Okay, our next presenter, for those of you that are here in the classroom, is virtual. Dr. Temple is going to be our next presenter. I will let her introduce herself and have at it. Make sure everything is working right. Dr. Temple, it's all yours.
Great, thank you so much. Thank you for having me here today. Yes, I am Courtney Temple. I am one of the emergency medicine and medical toxicology faculty at OHSU, as well as the Oregon Poison Center. And today I wanted to spend a bit of time talking about a very new and high yield topic for everybody, being pediatric fentanyl exposures. So we at the Poison Center have a great deal of very new and really compelling data that I'd also like to share. And I hope that a lot of this is new information for most of you. So I should have a little bit of time for questions at the end. So please think of them throughout, throughout my slides. I have no financial conflicts of interest to disclose. And here is essentially the run of show for the hour. I want to talk a little bit about poison centers, what they are, why they're important, and why we use them. And then we will transition into a bit of opioid pharmacology and epidemiology. And then I want to talk about our most recent findings. Some of our analysis has been quite robust in the data that we're getting, and I'm sure that many of you have noticed what's going on in the community. And then finally, we're going to talk about clinical effects, some treatment strategies, and then overall poison prevention. So in general, poison centers are medical facilities. We are able to provide immediate, free, and expert treatment advice by phone. So we field calls for almost anything, truthfully. This can range from household products to medicines, plant and mushroom ingestions, depending on the season, bites, stings, food poisoning, fumes, pesticides, foreign bodies, you name it. We are there to help with all of these types of things. And we're available 24 hours a day, 7 days a week. So anyone from the general public or a healthcare facility or pre-hospital personnel can call a single number and they will be routed to their local center. From there, a specialist in poison information, which we affectionately call our SPIs, our SPIs, which is a highly trained nurse or pharmacist. They are going to be the ones initially picking up the phone. And then beyond that, if there is a very severe case, something very unusual, or something that we have flagged in our protocols that needs medical backup, there are fellows in medical toxicology as well as board certified attending toxicologists on backup call at all times. And we are mostly made up of emergency trained physicians, although there are pathways that you can get there through other fields like pediatrics or family medicine, but most of us are EM. Healthcare facilities are able to speak to the on-call physician at any time. The other thing is that there are a lot of us. So there are 55 poison centers throughout the nation. Some states have more than one, so like California has 4, and some don't have one at all. So it's covered by another center. So for example, here at the Oregon Poison Center, we cover the entire state of Oregon, but we also cover Alaska, we cover Guam, and we cover the Mariana Islands. So between Oregon and Alaska, our catchment area is pretty big, and it becomes very rural in some of these places. Some places are quite isolated, like Guam and the Mariana Islands. Some of our treatment and care strategies have to change based on the location of the calls that we're getting. So why would you call us? Again, we are a public medical consultation service that is free to the community, which is very unusual, but hopefully makes an impact on all of the people in our community. But one thing I do want to mention is that calls to our centers will impact our funding. We are federally funded, so the volume of calls and the types of calls do impact our federal, state, and institutional funding. And this is actually a photo of part of our call center on the right. And we have shelves on shelves of obscure textbooks, case reports, the most recent literature, so that we can field even the most unusual calls from wherever the patient is. So not only are they an incredible source of advice, but poison centers save money, and it's actually quite a bit of money. So you can see here, this is from the American Poison Center's statistics. For every dollar invested in the poison center, over $13 is saved in healthcare costs and productivity. So that's not nothing. That translates into millions of dollars across the country. And not only that, but this is what has become very important, particularly for what we're going to talk about today. But it allows for national surveillance for ingestions and exposures. So the National Poison Data System, or NPDS, is the data warehouse, essentially, for all of the country's poison centers. And it helps identify trends, provides truly priceless research information, and it can even trigger the CDC when increasing numbers become worrisome. So again, think today, pediatric fentanyl certainly, but also things like botulism outbreaks. Many of the severe cases we were seeing with ivermectin or other alternative COVID treatment strategies, we were able to take all of that information and sort of characterize it further based on the calls that came in through the poison centers. And this information is uploaded in near real time, which is pretty fascinating for such a large database. Across the nation's poison centers, and this is 2021 data, but there were more than 2 million calls. So for every 1,000 population, there were 6.1 poison exposures. And for every 1,000 children under 6 years old, there were 37 poison exposures. And that was one call every 15 seconds. So that's pretty substantial in terms of the volumes that we are addressing. At our poison center in Oregon, we have over 50,000 new cases per year. And that roughly comes out to about 140 cases per day, which translates into 30 hospitalized patients per day. And again, for those of you who have called us, our phone is answered by our advanced trained nurses and pharmacists, but then we also have our round-the-clock medical backup. And there are 16 of us attending toxicologists. So there's someone available at all times. In general, of course, the purpose of the Poison Center is to treat poisonings, but also one of our major initiatives is really to prevent them. So one of our goals certainly is avoiding unnecessary ER visits and enhancing care, whether these patients are calling from their home about themselves or their children, or providers calling pre-hospital or from healthcare facilities for real-time expertise and recommendations. But it's the syndromic surveillance that is such a huge piece of our role in the community. So all of these calls are extremely important for us to monitor poisonings and exposures. One aspect that everyone may not be as familiar with is that we do a great deal of public health outreach and education. So that ranges from putting on a National Poison Prevention Week across the country. We go to the Science Museum, we go to health fairs, and we do campaigns for safe medication storage, which I will touch on at the end, just so everyone is sort of aware of the initiatives that we have ongoing in the community. Okay, so to jump into some of our data, as you can see, most of our calls involve children, and that top number is children less than 19 years old. But if you break that down, you see that almost half of our cases are in children under 6 years old. And you can probably imagine that there's a very good reason for this. This is the toddler age group that engages in a lot of accidental and exploratory ingestion. So children that are crawling, walking, and putting things into their mouths. So this is the age group that we have focused on for some of our findings today. This is the National Poison Center report in 2022 regarding exposures throughout the whole country in children under 6. The majority involve fairly benign things that can stay at home, not always, but most of the time. things like cosmetics, personal care products. That's followed by cleaning substances, think under the sink type household ingredients, although regulations, product changes, packaging formulation, all of those things have actually led to significantly improved outcomes. So for example, cleaning supplies are much safer than they were a decade ago. And there have been so many health campaigns to put prescription medications and dangerous hazardous chemicals up away from the reach of children or to lock cabinets. So we certainly do see still exposures, but there have been significantly less fatalities from that. But to further break this down, the most common causes of accidental fatalities in this age group that are non-prescription tend to be carbon monoxide, things like button batteries, and then our street drugs like fentanyl and methamphetamine. Prescription-wise, the most common severe or fatal exposures are most often antidepressants, cardiovascular drugs, and analgesics, which are in all of these situations, these medications or substances are not being used by the child. They have found them and ingested them. So a bit of history on fentanyl just before we start, because I think it is the magnitude of the problem has become so profound, but it is new for us here on the West Coast. So fentanyl really was not common in Oregon until about 2020. And as many of you probably recognized prior to that, the dominant illicit opioid was heroin. So the fentanyl crisis really hit the East Coast over the past 5 to 10 years, but we hadn't seen much out here, like certainly not to this magnitude until the past 3 to 4 years. Since that time, there has been a really robust surge in adult use and overdose, but we started to notice a signal indicating there were increases in very small children that were exposed. And just a note, the fentanyl that we're seeing is largely being manufactured in Mexico. That's where it's coming from. It's being transported to the US across the borders, the same illicit trading routes that the other substances are coming through as well. Usually packed in cars or transported through tunnels, just like heroin and methamphetamine. And I actually have a bit of data to describe the sheer scale of what we're seeing, and I'll get to that in just a couple of slides, but the volume of the influx into the country is quite profound. So we're going to focus on illicit fentanyl, which is an opioid. It works the same way as pharmaceutical fentanyl, but just to quickly remind ourselves of the differences between these agents, our opioids our opiates are at the top here. They are our naturally occurring opioids from the poppy plant. And that includes morphine, codeine, thebaine, and noscapine. And from there, we enter the opioid umbrella of the synthetics and semi-synthetics. So fentanyl is going to be one of our synthetic opioids. And again, all of these other agents we probably are familiar with from pharmaceutical use. But fentanyl is going to be under the synthetic category. So what is the big deal about fentanyl, really? It's a mu agonist, just like all of the other substances that we just talked about, all of our other opioids, opiates. But fentanyl is incredibly potent. It is 100 times more potent than morphine. And you can see over on the right here, the structures, despite utilizing the same receptor, they really don't look a whole lot alike, which is why for quite a while we were completely missing them on urine drug screens. While we frequently had high suspicion that fentanyl was on board, we did not have a great way to test for it. But fortunately, many hospitals, especially the pediatric hospitals, now have the capability to do that on their urine drug screen analyzers. So we are starting to pick up some of these cases, which is really what alerted us to what exactly was on board in these kids. In terms of dosing, so this is all going to depend on the route. For pediatrics, if we are treating with pharmaceutical fentanyl, either for pain or sedation, there's a range, of course, but we're looking at doses of about 1/2 to 5 micrograms per kilo. For oral transmucosal, that would be 15 to 20 micrograms per kilo. Intranasal, maybe 1 to 2. And then oral, which is not used very often, is about 5 to 20 micrograms per kilo. So just keep that oral dosing in mind for when we talk about what we're finding in terms of the ingestions for these children. The majority of fentanyl we're seeing are these pressed blue pills. They go by many, many names, like many of our illicit substances, but most often these are called M30s or blues. And apparently they were initially marketed to look most like OxyContin tablets. But these are illicitly pressed with pill presses in the community and then being distributed. We have started seeing isolated powdered fentanyl. It's certainly there, but pills far outnumber the powder in a very substantial way. So generally the way that these pills are used is people are smoking it off of aluminum foil. They're using a pipe or a straw and a lighter to heat that foil. And as the pill is vaporized, the user will inhale the vapor. And one of the benefits to the user in doing this is you're sort of able to self-titrate to the desired effect. You can imagine that if you ingested this pill, you do not have the opportunity to titrate to effect at all, and you are going to end up with that systemic dose, regardless of the way that you had intended to use it. So this is typically how people are using it. This is an issue in children, obviously, because they are finding the tablets. So what is actually in these pills? We collaborate with several initiatives to determine what drugs are in the community. And we've been doing this for several years now. There is a study group called DEA Talks that the poison centers around the country participate in. And we can send anything from drug samples, whether that's powder or pills or liquid, drug paraphernalia, and biologic samples to this work group that has very extensive mass spectrometry testing. If we think that there is a new drug that we're seeing, or there is just something different about the way the patient is exhibiting their toxicity. So this sample that you're seeing here is from Southern Washington. This is our blue tab. This one has an M on the front and a 30 in the upper portion of that score on the back of the tab. And what it contains largely, the thing we're most concerned about is the pure fentanyl, which is that second row down under the drug contents. The rest are contaminants. They're in very small quantities, and they're contaminants as a byproduct of manufacturing. And then the filler is acetaminophen. That's what the majority of the pill actually is. Not enough to cause liver damage. In this case, it's only about 100 milligrams in this whole tab. But there is 3.9 milligrams of fentanyl in this one tablet. We've found it generally fluctuates between 1 to 4. But remember, even with oral dosing, we are dosing fentanyl in micrograms. So this one tablet has 3.9 milligrams. So what does that mean? 3.9 milligram ingestion is equivalent to 3,900 micrograms. And again, typically we don't use PO. There is some data for preoperative sedation in kids that goes into the hundreds of micrograms, but in general, this blue tablet, the single tablet, is 39 times a sedating dose for a 10-kilo child. So this is some of our new, very exciting data, very alarming data. It was just published 2 days ago, actually, in the New England Journal of Medicine. This is the number of children under 6 exposed to illicit fentanyl. So we excluded prescription and pharmaceutical formulations. So no lozenges, no patches, no in-hospital inadvertent therapeutic misadventures, nothing like that. Those were all removed. And the goal of that was to capture children that were being exposed to the illicit, clandestine, manufactured fentanyl in the community. So on the x-axis are our years. We looked back to 2013 up until 2023. And then there are two y-axes. The left is our national data, and the right is our state level data in Oregon. So you can tell our cases had a little bit of a delay, which makes sense when you consider that the epidemic really started on the East Coast, and we sort of saw it trickle across the country to the West Coast, really after COVID had hit. But now we really have matched the rise with the rest of the country. The children in our study were very severely ill. 69% of them needed Narcan. They had major CNS depression, and we broke that down into different categories, but the major category was really characterized by coma, unresponsiveness to physical or verbal stimulation, and apnea. And one of the most alarming things that we found was that most of these children were exposed in their own home. And that remaining 18%, we just did not know where the exposure was. So it's certainly possible that it is closer to 100% of the children that were exposed in their own home. So these are not exposures happening out in public, in parks generally. And that is why this has become not only concerning because of the exposures and the way to treat these children, but we really need to figure out quickly how to perform risk mitigation on things that are in the home. Additionally, the median age of these kids was 1.6 years old. So we're landing right in that toddler range age where exploratory behavior is so concerning. So if you take a look at that blue line, up until 2020, Oregon had 0 cases of fentanyl. In 2021, all of a sudden we had 2. 2022, we had 9. And then last year we had 16. So the absolute numbers don't seem so high, but the severity of the cases is really striking. If you look at the rest of the country, which is in red, prior to 2020, we had, around 200-ish cases. We had more than that the following year in 2021. And in 2023, we jumped up to 539. So we've had like a 400% increase in fentanyl, and this is only in children under 6 in the past handful of years. So we went on to look at fentanyl seizures in the state to say, can we sort of make any decisions about, is it that the fact that there is more fentanyl in the community? Is it the fact that we're just picking these up on urine drug screens? Like, what is going on here? So the green line is the same data from the last slide, our Oregon data. The red bars are the pills that have been confiscated by the DEA per year. So you can see in 2019, fentanyl pills really were not much of anything. And then in 2022, there were an exceptional amount of doses that were taken off of the streets by the DEA. The powder is in blue, so you can see it's a much, much lower fraction of the fentanyl containing products that we're seeing. And this is really where I think you can see the remarkable increase, not only in powder, but pills. That's just between 2019 and 2023. So on that y-axis, you're seeing dose units, and that is meant to make an equivalent comparison between powder and pills, so that we can try to determine what the volume is that they're actually removing from the community. So in 2019, there was about 100,000 dose units that were seized, and that came out to about 1.5 kilos of powder and about 100,000 pills. And then in 2023, we have increased in an unbelievable fashion to 107 kilos of powder, over 2.6 million pills, and that's about 2.7 million dose units. So from 100,000 dose units to almost 3 million dose units of fentanyl that has been just confiscated. That's not even still what's out there, and that's only between 2019 and 2023. So how are children getting exposed? It seems like it could be fairly obvious, right? Ingestion of a pill looks like M&Ms, it looks like other candy. And again, most in our study were between 1 and 2 years old. So perfect age range to mistakenly put things in their mouth. Some cases do involve ingestions of powder, but it's pretty tough for kids to ingest powder though. This isn't going to be something where they are emptying a baggie into their mouth. Mostly it is handling, touching, finding powder, and then putting their hands near their mouth or in their mouth. But we do have some exposures, but by and large, these are majorly pill ingestions. So let's talk about the clinical effects, which I'm sure many of you are very, very familiar with at this point. But what we expect to see primarily is CNS sedation and respiratory depression. Those are the big ones, along with meiosis, so very tiny pupils. The patient is going to be very, very sleepy, and it's going to decrease their respiratory rate. But not only that, they're also taking more shallow breaths. So you're decreasing not only your rate, but also your tidal volume. And these effects are dose dependent. So the more fentanyl you give, the more shallow you breathe and the less times per minute. These graphs are really serving to show that it's the respiratory rate and the tidal volume that are impacted. But interestingly, respiratory rate is impacted pretty comparatively with morphine, heroin, and fentanyl. Those are those blue, green, and red lines on the right side of the graph as compared to saline. So they all decrease your respiratory rate. Maybe morphine has a bit of a lag time, but they all end up fairly equivocal compared to controls. On the right, it seems that fentanyl is really impacting the tidal volume more so than some of these other narcotics. That's the red line down the bottom, significantly different than morphine and heroin. So if you take 40 times the sedating dose, this is going to have a really significant impact on the depth of your breathing and how fast you're breathing. And again, this is how these dose-dependent effects really are. This is the data from the prior chart showing dose-dependent relationship of fentanyl. So the y-axis is percent of baseline tidal volume in minute ventilation. That bottom-most line is our max dosing from the prior slide. So if you give 0.05 mg per kg, you're going to have less effect on the depth of respiration than if you give 1.35 mg per kg. So truly is going to be very dose dependent. And you can see from a normal oscillating respiratory pattern, if you give that max dose of fentanyl, that transitions from that really nice waveform on the left to this really concerning waveform on the right. Frequency is impacted and our amplitude, our depth is also impacted as well. So we're going to expect to see the same exact effects with oral ingestion as any other route. It's just that the overall dose is so much higher in these exploratory ingestions that the symptoms are so much more severe. So from a clinical standpoint, monitoring ventilation with capnography, if it's available to you, and saturations are going to be the most helpful to determine how severe this respiratory depression really is. So we really want to look at the number of breaths per minute. We want to make sure that they are ventilating by looking at the end tidal, and we want to make sure that they are oxygenating by looking at the oxygen saturation. We're going to expect some different findings in children though. So again, I want to reiterate that the doses in these pills are so large that these very small children are being exposed to. We're seeing a prolonged toxicity that we really previously hadn't seen. So, typically we think of fentanyl as short acting. That's how it was built to us as a treatment strategy. It has a short half-life. It shouldn't stick around that long. And that's true in adult and adolescents. Effects usually don't last more than a few hours. But in children, we may have a couple of different reasons that aren't just because of these massive doses that they're ingesting. There is an enzyme that is the main metabolic pathway for fentanyl, and newborns essentially have zero activity of that enzyme. So it may be very prolonged based on toxicokinetics, and I'll just talk a little bit about that on the next slide. But more than likely, these days-long presentations are just because of the massive doses. This is getting into a little bit more of physiology, but just briefly, the CYP3A4 enzyme, which is in our liver, that's what's responsible for the metabolism of fentanyl. So again, not active in newborns, but generally was thought to have complete activity by 1 year of age. That may not actually be the full case, and it may not be quite 100% fully active until adulthood or at least advanced adolescence. In fact, actually, CYP3A4 metabolizes most of the pharmaceutical medications that we use. Beyond that, it's highly variable in the population, so much so that it can vary 30-fold between one person to the next. So you can imagine how the way that one person metabolizes could look very, very different from another person who took the exact same dose with the exact same route. And just below that, these are inhibitors and inducers of this particular enzyme. So there are a lot of antibiotics on here, some calcium channel blockers. Grapefruit, of course, is one that comes up very often as interfering with some of these metabolic pathways. But if you have one of these on board, you can significantly impact the rate at which you're going to metabolize your fentanyl. And then below that, those are inducers, which effectively should speed up the metabolism of fentanyl. But if any of these are on board, you may not know, you would expect that the metabolism would be affected in one way or another. I will give the medical director of the Poison Center credit for this slide. And it's meant to show why we think this is affecting children so substantially in a visual way. So our y-axis here is fentanyl concentration in the blood, and the x-axis is hours after the dose is ingested. So if we want to sedate a child, we will give the appropriate dose, and as the blood and brain concentration goes over that sedation line, we should not be hitting apnea. So that's that white line. And you can see it works pretty quickly and then sort of metabolizes over the course of a couple of hours. For an overdose, for however that has happened, either unintentionally or recreationally, we are in the over-sedation zone, causing the patient to potentially become slightly apneic. Let's say that's 5 to 10% too much, right? We come right over that line of apnea, and then we can hopefully give a small dose of Narcan to get them back into a safe sedation zone. For a 1.5-year-old with 40 times the dose, we're more in this yellow line region. So that concentration is going to stay over the apneic threshold for a very, very long time. We have seen 2 to 3 days of very severe symptoms requiring ICU care. And again, this is likely ingestion of pills. If a child is exposed to powder, they get a bit of powder in the mouth, we're probably looking more at the green line, to be honest. It's really these massive ingestions that are going to stick around for a long time because it really impacts the way that we metabolize. Once we have an overdose to that degree, we can't really rely on the kinetics that we're used to predict how long this is going to last. So urine drug screens, also another hot topic issue. Fentanyl does not show up on traditional drug screens without the specific assay. So in the past, we have been testing for morphine, which is also going to catch our heroin. And that's what we've been testing under the opiate category in the urine drug screen. Now we do have specific screens for fentanyl as well as oxycodone. And that has made our job a lot easier in terms of identifying what opioid is actually on board. So many of the pediatric hospitals have added this to their urine drug screen analyzers, and many of the adult hospitals have done this as well. Unfortunately, there are some medications that can cause false positives. It is not a common occurrence, and certainly you can see on this list, these are not medications that children less than 6 are typically exposed to. That's not always the case, but it's fairly uncommon. So most children with a positive urine drug screen, that's going to be true fentanyl. But several things obviously are causing false positives. Sometimes labetalol, risperidone, things you might not really recognize. There's one case of diphenhydramine at extremely high concentrations that caused a false positive on a very particular analyzer. And that came out of our poison center as well. So if this was a situation where it was very surprising to have a positive fentanyl in the urine, and even if there was fentanyl in the urine for a child, we would urge anyone who's caring for that patient to call the poison center, and we can help sort through all of that. We will often send extended spectrum testing to third-party laboratories that do advanced GC mass spec and things like that. Okay. So let's talk about treatment strategies, because this is really going to be the emergent component of this, especially pre-hospital. There's been a lot of debate in the past about dosing and frequency of Narcan, so we can get into some specifics about the best course, and we are just learning about the best ways that we can impact the severity of these overdoses as quickly as possible. So as our knowledge evolves of this ongoing problem, we are going to evolve our recommendations. But for the moment, let's go through the things that we think are pretty important for you all to know. So first, naloxone is a competitive antagonist at the mu receptor. So it competes for the exact same receptor that fentanyl is occupying, and it replaces that space. If you have to reverse just a little, you can use a little bit of naloxone. If you have to reverse a lot, then you're going to need a lot more. What I think is really interesting is in the past, it was presumed that we needed far higher doses to reverse fentanyl itself. But what we found is that it actually doesn't require higher doses. Most of the studies on adults and adolescents with fentanyl overdoses show that it does not require excessive dosing, no more than heroin or actually any other opioid. So in the cases where substantial doses of naloxone have had to be used, it's probably because the dose of the overdose is so large. So just quickly, here is one of the studies that concluded that there is no difference in naloxone dose in patients with fentanyl compared to heroin overdose. And of course, to clarify, those are dose equivalents, right? Like that would be the same comparative dose for someone who overdosed on fentanyl as to someone who overdosed on heroin. And this was from the Journal of Medical Toxicology in 2020. So in terms of dosing, usually we are, trying to use the lowest dose of naloxone to reverse someone out of their apnea. This is for adolescents and adults that generally use recreational opioids chronically. We want them to be breathing. It is not so much that we need them to wake up. Being sleepy is still okay, but we really do not want to precipitate withdrawal. If you've ever seen that, it is quite difficult to deal with and difficult to treat. So that's usually why we say go low and slow. However, for pediatric accidental overdoses, it's very, very unlikely that the child is getting high doses of opioids on a regular basis. So there is very little risk of precipitated withdrawal in general. Of course, there are exceptions to all of these things. And you may elect to start with a small dose, but we recommend escalating very, very quickly to high adult doses. And I'm going to say this a couple of times. Please do not hesitate to use full adult dose Narcan in a severe situation with a child of any age or weight. It is perfectly safe. So as an opioid antagonist, naloxone really has minimal adverse effects in non-tolerant patients, meaning patients who don't take opioids on a regular basis. Large IV doses in these naive patients led to a slight increase in blood pressure in one study, but otherwise really was extremely well tolerated. And that study actually just shows the way that it can affect the endogenous opioids in our system. We all have endogenous opioids, and naloxone may reverse that, but it is not going to put you into a state of withdrawal in the same way as if you have an exogenous opioid on board. And again, generally precipitated withdrawal is not a concern in small children in the vast majority of cases. So in terms of a dose plan, following your pre-hospital protocol is completely reasonable. But again, we would ask that you consider escalating very quickly. If you are using intranasal, if that is the first thing that you are able to reach for and it is the fastest way to get that into the child, please use that, and please use the full adult dose. Again, it is perfectly safe, and that is what we would recommend for you to do without hesitation. This chart is also from the New England Journal of Medicine, and there's quite a few details in here, but really what I want to impress upon you is that this includes adult and pediatric dosing of Narcan, but it essentially starts with a single dose for each of those age groups, and then it immediately all fuses together. So you're going to end up with 0.5 to 10 milligram doses, regardless of age or weight. And it would not be unreasonable, again, to start with max dosing for a child with a coma. So I want to talk about kinetics just for a second. It does take a minute for the naloxone to kick in, and even IV administration can take up to 2 minutes technically. Intranasally can be several minutes, which is why we often are recommending to pause before giving that second dose to let the patient sort of wake up if they're going to. And then the duration of action depends on dose and route, but it generally lasts about 20 to 90 minutes. Remember, fentanyl is going to stick around for a couple of hours, so it's reasonable to assume that as the Narcan wears off, you may need to retreat depending on the severity of that overdose. So we're going to head back to our large graph about pediatric ingestions. Usually what we're trying to do is give someone a bit of naloxone to get them to where that tiny blue arrow is on the left. We just want them breathing. We don't necessarily need them to wake up and talk to us. We just need them to be in a safe sedating range from which they can be monitored. So bringing them from just above that apnea line back down to just sedating, a sedating dose. However, for a child, when we're trying to combat these very, very large concentrations, you are going to need to give enough Narcan to compete with what is present. And that generally is going to be multiple high doses, and that may even turn into an infusion or a drip in hospital. And that's that large blue line, like we are trying to get them down from this huge yellow curve back down into a safe sedation zone. So again, may likely need multiple doses. The naloxone half-life is about an hour. Fentanyl half-life is a handful of hours, about 5 hours. And that, of course, depends on your metabolism, but that's the average. So we need to be prepared to monitor these patients in terms of their ventilation, their oxygenation. And then we would predict someone who got a very large dose is going to need multi-dose Narcan, and then potentially a drip. And that we dose at 2/3 of the initial dose that the patient responded to. And then we would put that in an infusion per hour. So that's my perfect naloxone dosing plan. And of course, there are things that are going to interfere with that. Co-ingestions are going to be one of them. And hopefully this applies mostly to adults who have ingested a polypharmacy overdose. But certainly we could also find this in children with exploratory behavior or adolescents who have purposefully ingested multiple things. Also, aspiration and respiratory compromise might be a barrier to us. If there are 0 respirations and no circulation, that may very well impact the effectiveness that you will have administering Narcan, and you're going to have to continue to do advanced life-saving care, rescue breaths, chest compressions, whatever is called for in that particular situation based on ACLS. And there are, of course, limitations based on dose and route of Narcan. So starting with a low dose, you may require more time to get to the symptom improvement that you're looking for. So prolonged time to improvement versus a large dose of IV medication. Subcutaneous, we don't often use that. It tends to be very difficult to titrate, and that sort of extends not just Narcan to a lot of different classes of medications. Intranasal, especially when administered by bystanders, can be a bit unpredictable. It's one of the reasons that we really try to make sure that people understand how to use their home Narcan, because often we're getting reports that X number of doses has been used and we found no effect, but there is some user error that's possible with that route. It is certainly still the best thing for bystanders or expeditious pre-hospital care. If that is the first thing that you can reach for, absolutely we recommend that you give that. But in hospital, we're not recommending intranasal as first line. There are also instances where we can get a little bit fancy and we can nebulize Narcan in saline and administer that through a non-rebreather. Again, you can imagine that that is only really feasible in a very certain patient population. It was initially designed to try to help us avoid that precipitated withdrawal, sort of let the patient self-titrate their naloxone. They're able to take off the mask when they're awake and breathing again. But of course, this would be limited in people with severe respiratory depression. And again, dose accuracy is extremely difficult to estimate in these sorts of circumstances. Okay, so co-ingestions. There's a lot of stuff out there that people can co-ingest. For a while, we had these Xanax bars or Xanny bars. This is not pharmaceutical Xanax or alprazolam. These are pressed tablets that are made in the community, just like our M30s are being manufactured with physical pill presses. They previously contained quite a few fentanyl analogs, acetylfentanyl, fluorofentanyl, all of these sort of newer manufactured derivatives of fentanyl. And there was no kinetics data on that when it was coming out. Also, there were a lot of other benzos in these Xanny bars that weren't alprazolam, things like bromazolam. And we didn't have a lot of clinical experience with that when they first came out. As you can imagine, the illicit substance scene moves much more quickly than we can keep up with, both in terms of legislation and testing. So we do our best with all of these studies, and a lot of it is looking back to see what we have learned from previous clusters of unusual overdoses. That being said, this has all largely disappeared. We are currently doing a study looking at opioid overdoses, mostly adolescents and adults, getting blood samples to determine what else is in the fentanyl. And in the last 6 months in the opioid overdoses, we just found plain fentanyl. There's no xylazine, there's no analogs. However, people tend to co-use meth, so we do generally pick that up. This is our Fentanyl study. This is ongoing across the country, and we are one of the primary sites for this in the ER at OHSU. We are seeing extremely small numbers of xylazine, and actually the cases in Oregon are effectively 0. We technically had 2 but they were xylazine containing pills that were brought into the state by visitors. So we have no native xylazine in our supply at this time, as far as we're aware. Xylazine is a veterinary sedative, so it works just like clonidine or dexmedetomidine. So CNS depression, and also it affects your pupils as well. You will get small pupils with that, but it alone should not produce the respiratory depression that we see with opioids or fentanyl. It's meant for sedation in a veterinary setting, but it can also cause bradycardia and hypotension in the same way that clonidine or dex can do that too. We have had multiple cases where it looked like xylazine was on board, really profound CNS depression that we were having trouble reversing with Narcan, or very prolonged CNS depression. And after extended spectrum testing, all we found was just plain fentanyl. And they started being labeled as fentanyl non-responders. So those were most likely these massive doses that someone had purposefully taken, and they just needed a large, frequent dose of naloxone over a longer period of time than we otherwise would have expected. If you were to take fentanyl and xylazine, you would be able to reverse the fentanyl with Narcan, but not the xylazine. So the patient may start breathing, but they may not wake up. And again, we have not seen any of this in Oregon, but there's a lot of data coming in from the East Coast, but it is not in our supply yet. Hopefully it will stay that way. But we should be aware that it is most likely coming and is just experiencing a bit of a lag, the same way that we had a lag in our fentanyl crisis. Okay, brief review. These tablets are huge doses. In children, we're going to expect profound CNS depression and apnea. We may need large doses of naloxone, repeated doses of naloxone, and prolonged effects that last possibly days. So again, please give adult dose Narcan if it is indicated for a severe overdose. Perfectly safe. The goal is to get the child breathing again. They do not necessarily have to be awake as you transport them, but careful monitoring of respiratory status will be helpful in terms of when to redose. I want to start to wrap up with a little bit of poison prevention, because I think the work we need to do in the community is now evidently so much more than targeting just our using population. So we want to treat the adult using fentanyl, but we also want to engage in aggressive risk reduction for those in the home. Most of the initiatives in the past have been to prevent overdoses and exposures to pharmaceutical drugs. Very few initiatives have been to target substance use disorders in adults that can then translate to the children in the home. So we're trying to expand teaching to these adults who have opioid use disorder, who either have children or are in contact with children, whether that's grandchildren, nieces and nephews, they have people in their house, friends, children, any of these situations. Up and away has been the dominant strategy thus far, meaning all over-the-counter meds, script meds, illicit substances, up in the cabinets, away from children, or in locked cabinets, or just out of the rooms that they spend time in. So we really are hoping to engage more with adults that have substance use disorders, so that they can understand that these, whatever they have in the home, whether it's powder or pills or paraphernalia, these need to be treated in the same way that we treat very dangerous pharmaceutical medications that we keep away from children. Another component of this is physical storage solutions. And this solution actually comes from the cannabis industry, and they are lockable boxes and bags. They're designed to store cannabis products, but there's absolutely no reason that they can't store illicit drugs or paraphernalia. And they come in various sizes. Some have child-resistant snaps, and some have locks. Many of them are very, very inexpensive, something like less than $10. And there is actually a very eloquent study that was done with pediatric patients in looking at the time it takes for them to access pills in child-resistant bottles and lock boxes in bags. And when you properly store the medications, it tends to take the smaller children so long to get around the mechanisms that they get quite bored and they actually leave them alone. So it has actually significantly impacted the way that they are able to break through the child-resistant mechanisms. Obviously, this is not for intentional ingestions with adolescents. They certainly can cut these bags open. Here's an example of one of them. You could take a pair of scissors or a knife to this, certainly, to get in. But this particular bag is one of the more expensive ones, more than likely. You can see that it has a locking mechanism with a simple code and a release button, and it's able to keep those 2 zippers locked until you choose to open it. So again, usually very inexpensive. There are also lock boxes and soft locking sort of lunch bag type containers. So for anyone with opioid use disorder, and now for patients that we're discharging from the hospital with opioid prescriptions, mostly oxycodone, we are discharging them with a prescription for Narcan. We want to make sure that everyone who has opioids in the household has a reversal mechanism for any accidental exposures. It doesn't matter if it's children, it could be an elderly parent, it could be a developmentally delayed family member. We want to make sure that that is in the house and that they know how to use it. It is over the counter also, but you do have to go back to the pharmacist. And it's covered by most insurance policies, actually, and if it's not, it's a very small number, but it's not prohibitively expensive anymore. It's covered by OHP. It is $45 for the 2-pack, so it's not nothing, but hopefully for families that do truly need that, it's not completely inaccessible. And again, I know I said this several times, but please use adult naloxone on children. Do not hesitate. It is perfectly safe. Just 2 more plugs for the Poison Center. If you all ever need anything related to overdoses, informational questions, whatever sort of reason that you would need to interact with the Poison Center, and you have a language barrier with a patient or a family member, we have 22 languages available and real-time translators that can jump on the phone with us to help. And if we don't have it, we can find it. Our spies are incredibly facile with finding translators in a timely fashion so that we can help you in the most expeditious way possible. We also have a QR code if you're interested. It can add the Poison Center number directly onto patients' phones. So we do have an initiative where when we're discharging people in safety planning, we really want to have them have this on their phone, whether it's an adolescent who is mid-crisis or family members who are dealing with that as well, or just anyone in the community that would like to have this number ready for them. This is the QR code to add it to their phone. And if you feel so inclined, our website has an abundance of resources for poison prevention and campaigns, as well as education. So you can contact us anytime. Please use us as a resource. This is why we trained. We love to take these calls. You can always speak with the toxicologist on call. We have 4 fellows who are amazing, 16 board certified faculty, and you only need to call that one single number, which will direct you to your local poison center. So that's 1-800-222-1222, but it is going to direct you to the poison center based on your area code. So just be aware of that. And whoever you get in contact with can then reroute you back to where you are physically located. And with that, I will take any questions.
All right, any questions for Dr. Temple? Josh?
With the high doses of the Narcan, was there any of the flash pulmonary edema? I know it was taught way back when pulmonary edema was a side effect of Narcan.
Did you hear that, Dr. Temple?
I think I did. Yeah, that is an excellent question. It is always something that we worry about, and we don't see it very often. As far as our data showed, none of these children had signs of pulmonary edema from the Narcan. Most of the very profound sort of systemic effects were because the child had already been down. So I would say no, we haven't seen that, and I wouldn't hesitate to move forward with high doses, even if that sort of was in the back of your mind. Treat the child first. We can address pulmonary edema if that were to happen later. I really have only seen that in adults, and I don't have a great reason for the difference in physiology. And maybe it's just because we have not seen it yet, and it is possible. But again, we haven't seen that with high doses in children quite yet.
All right, Chris, you had a question?
I'm trying to figure out, on the CDC side, you can look it up, and it'll tell you how meth is made. But what is fentanyl made out of? Is it a powder they're bringing in the United States, or they're making it here?
Oh, I'm sorry, I didn't quite hear that one.
So the question is, what are they making fentanyl out of? I understand that we make meth here. What are we making the fentanyl out of that's coming into the United States?
Oh, like what is the actual process to manufacture it?
Right, so I assume
That
it's coming as fentanyl.
it is coming in as fentanyl. That's not to say that it's not being manufactured here in clandestine labs in the same way that meth is, but actually we have seen quite a transition from the manufacturing of methamphetamine from those small sort of home laboratories that we're having very concerning explosions and fires from. That has diminished by quite a bit, even in the Midwest, and has really transitioned into large-scale manufacturing in Mexico. Most of our meth and our fentanyl is coming in from the South. That's what we've been seeing, and it is largely the same groups, the cartels, that are manufacturing this, and they're bringing them in together. So there is a massive process for manufacturing this. A lot of chemistry is involved, and I can't speak to where they get their supply of precursors and things like that, but that is generally what's happening. They're making them together, and they're coming through the borders together.
What chemicals are they using, and do they burn?
No, so it already comes over as fentanyl, and they're just making, as the doctor said in her presentation, they'll combine it with like Tylenol or other binders, but they're cutting the bigger, stronger doses of fentanyl into smaller doses of fentanyl. So it's already fentanyl when it comes here.
That's right.
And the last question we got before our break, one question online: do you see any pediatric cases of carfentanil?
Oh, excellent question. No, we have not. And very, very thankfully, we have not picked up very much of that in any of the testing that has been done across the country. It has certainly been seen very, very small amounts in some of the testing that has gone through that DEA tox study group. And as far as I can recall, it is always formulated with something else. So either a contaminant, a byproduct of manufacturing in a particular tablet or formulation of a substance. But it usually is not the main ingredient. Carfentanil would be even more alarming if it were to become prevalent in the community, because it is even more potent than fentanyl by a large degree. So the answer is no, we really haven't seen that. I truly hope that we don't start to see that because as you may know, that is indicated for large zoo animals as a tranquilizer. So we're talking elephants, giraffes, we're talking massive, massive animals. So for human ingestion, it is universally extremely severe and likely fatal.
Okay, well, we'll cut it there because we have a shorter break before the next presentation. So thank you, Dr. Temple.
You're welcome.
For the presentation.
Thanks for having me.